Good afternoon, everyone, and you are very welcome to this episode of QPS Talk Time. Please do follow us on social media. You'll find our previous QPS Talk Times are available to hear and watch on YouTube, and you can follow us also on LinkedIn. And yes, news flash here. We are also now available on Spotify with the QR code there. We'll take you to that. And so there's no excuses now for not being up to date with QPS Talk Time. Just again, to make people aware, this was the subject of a QPS Talk Time a few weeks ago. It's the new Quality and Patient Safety Competency Navigator. Again, the QR code will bring you to the document, which is it's an online document, and it's really there to guide people through assessing and then improving their own competencies in the various domains of quality and patient safety. And I think we really want to see people engage with that document, and I think hopefully you'll find it very helpful. Please, if you're not using it yourself, do tell other people about it. And also just to flag our prospectus for quality and patient safety education and learning programs for 2025. Again, the QR code will take you to the prospectus, and you can find lots of different programs there for you or your team or your colleagues, from a huge range of things, from online learning to taught in-person courses. So please do check that out and follow the QR code again. So today we are going to learn about human factors in healthcare, and human factors become very topical and lots of interest in it, but I think there still remains a little bit of mystery as to what it is. So we're going to learn a little bit more about that. Going to hear national and international examples of human factors in practice, explore the conditions that enable application of human factors in practice, and we're going to share with you some examples and resources available that will allow you to learn more, including the HEPS conference, which is going to happen here in Dublin in June, and we'll tell you more about that later. So to do that today, we're very lucky. We have a very esteemed panel of speakers who are going to deliver some presentations, and then we're going to have some conversations. So I'm going to start at the top there of the slide. So Francesco Vianeri is joining us, I think, from Florence in Italy. Francesco is an emergency surgeon and physician at the Mugello Hospital, Italy. I hope I pronounced that right, Francesco. You can correct me. And Francesco has a long-standing interest in human factors in healthcare. Maureen Nolan is also joining us. Maureen is from Patients for Patient Safety Ireland and is the Patients for Patient Safety Ireland rep on the HEPS conference committee. And Patients for Patient Safety Ireland have always had an interest in all things connected to patient safety, including human factors, and have been most supportive. Next there you can see is John McElhenney. John is Quality and Risk and Patient Safety Manager, Acute Hospitals Northwest. And again, John has an ongoing interest in patient safety and the use of human factors within patient safety. And we're going to hear from John about his thoughts on that. And then Veronica Hanlon from the HSE is an educationalist in the National Quality and Patient Safety Directorate, and was really key to putting together the QPS Competency Navigator that you saw there. So we've a great panel. I think I'm joined by Juanita, who's going to co-facilitate the session with me, and together we'll be watching the chat and trying to get to your questions. So everybody, you're most welcome. It's suiting now. I'm going to introduce Liam because Liam's our first speaker. So Liam is co-founder of One Unit, collaborator and supervisor at the Irish Centre for Applied Patient Safety and Simulation at the University of Galway. And again, I've worked with Liam for many years, so it's a real pleasure to see Liam here today. And Liam, you're going to start off really just telling us, giving us an introduction as to what human factors is in healthcare. And over to you. Thank you.
Great. Thanks so much, John. So yeah, I was asked to sort of just give an introduction to human factors and ergonomics, and I thought I'd start off with the boring standard definition for everyone to sort of get their heads around. So the International Ergonomics Association defines ergonomics as the scientific discipline concerned with the understanding of interactions among humans and other elements of a system, and the profession that applies theory, principles, data, and methods to design in order to optimize human well-being and overall system performance, which is quite a mouthful, really. But really what we're trying to do is make the system work as well as it can for the people and the people within the system itself. Um, Another sort of common question, I suppose, is whether it's human factors or ergonomics, which term am I supposed to be using? And honestly, you can use either term. The terms are used interchangeably. There is a little bit of a tendency towards using ergonomics more around office work and measurement of physiological anatomy and those sorts of aspects of care or service, whereas human factors tends to be used a little bit more in terms of healthcare, safety critical systems, public transportation systems, aviation, energy systems, etc. So that's sort of just the sort of bare bones definitions, I suppose, of human factors and ergonomics. But the scope of human factors itself actually is quite large, and probably a lot larger than people really consider. So the first part, I suppose, that we sort of look at within human factors is at the lowest level, the anatomy and physiology. What are the impacts of anatomy, biomechanics, aging, audio and visual systems, musculoskeletal disorders, repetitive strain injuries, physiology? How do these impact staff and their ability to deliver their work? And how do we optimize to reduce these things and to ensure staff are able to perform at a high level? Moving on from the anatomy and physiology, we're onto the sort of psychological aspects of individual performance and team performance. So things like behaviors and attitudes, change management, communication, organizational culture, what sort of decision-making systems are in place within our work. What about group behavior? There's some really interesting experiments from, even the 1970s looking at the impacts of group behavior on individuals' responses to questions. Job satisfaction, learning, leadership, memory, all these things all sort of fall in within the scope of human factors. Moving on then from psychology, we're sort of starting to move up a layer a little bit. We're starting to look at the people and the systems themselves. So we're talking about communication systems. We're looking at human-machine interaction, human reliability and human error, job design and job aids. One of the examples we can look to is, the early warning score system that's used nationally within the health service. Organizational learning and organizational change, product design, process analysis, safety culture, shift work, socio-technical systems, systems engineering, teamwork, user-centered design, user experience, all of these things all fit within the scope of human factors and ergonomics practitioners' toolkit, I suppose, or scope of practice. And then sort of moving up again to probably the highest level, we sort of have what is the impact of our work environment, or how are we factoring or considering the work environment on our individuals and our teams? So everything from abnormal environments, those working in, extremes of temperature and cold, auditory environments. The average emergency department has a lot of alarms going on. There's a lot of communication happening. There's announcements over the PA system. There's a lot that can impact on our cognitive load and our ability to keep track of the work we're doing and what we need to be focused on next. Mechanical environments, maybe not as relevant within the average healthcare workers environment, but think about ambulance workers, paramedics, air retrieval services, the impact of working in a helicopter, vibration, noise, all of these sorts of things can have on your work. Then thermal environments, visual audio environments, all these sorts of things, sort of elements we need to consider. And all of this has to be sort of delivered or considered within a set of tools and frameworks and methods. Everything from anthropometrics, measuring human body, determining size and fit of clothes, all the way up to, broader systems analysis, data collection. What are the ethics involved with engaging patients, participants, families, staff within all this work? The evaluation of the work itself, experimental design. Once you actually do have an intervention that you want to try out, how are we going to design that? Focus groups, questionnaires and interview design, task analysis, and then the statistical methods that underpin a lot of these techniques. So the scope of human factors and ergonomics is broad. It's horizontally across the work that we do. It's vertically from the front line of care all the way up to the organization and how we are aligning and learning horizontally and vertically. So it has the potential, I feel, really, to impact on everything that you do. Once you arrive at the door of work, everything after that is potentially within the realm of human factors. Okay, so that's sort of my grand vision for human factors.
Have I lost Liam there?
Bean's laptop just crashed, so he'll join us, I think, in a minute. But we might move on, and we can come back to him in a moment.
Yeah. Okay. So I think we may come back kind of just to some scene setting, but I think next up we have Francesco, and I think Francesco, are you happy to maybe, knowing that Liam maybe hasn't explained everything there to us, you might come back to kind of point out one or two things to us, but I think you're going to kind of get us into some examples, kind of, and talk about the evolution and the application of human factors into healthcare, and we can come back to Liam in a few minutes.
Okay. Well, I want to thank you first of all for inviting me to this interesting webinar, but I have to say that before I met a number of friends who were dealing with human factors and ergonomics way back in 2005, I didn't even know as a surgeon what human factors are and what their effect could be on healthcare, and mainly on patient safety. And I read about this all through these 20 years, and I must say I've been so excited about it. And what I must say is that it was very hard for me, being a risk manager, trying to introduce these concepts in the Italian healthcare service. I'll talk to you about later the experience I'm having with the dean, the conversation I'm having with the dean of the Faculty of Medicine. I just want to talk to you about that afterwards. But let me say, first of all, to my fellow colleagues, which are mainly surgeons and neurosurgeons and all the operating room personnel, when I spoke about human factors, they looked at me in a strange way and they said, "Why do you want to speak to us about human factors? We're already humans." And I started laughing at them and saying, well, human factors doesn't mean being human. It means having some skills or understanding skills and try to apply them in our daily work as surgeons, nurses, lay personnel, trying to reduce the potential of harm in the healthcare system and mainly on the patient. So that's my experience, and may I say that it was amazing for me as a surgeon, and I'll talk to you about that afterwards, what I'm doing with my scientific association here in Italy on simulation practices. But I'll just reserve that at a later time, okay?
That's great, Francesco. Thank you very much, and I think we're looking forward to exploring more of that and hearing some of those experiences. John, I'm going to come on to you next, if that's okay. And again, just from your point of view, where do you think human factors helps us in, the daily application of patient safety theory and practice into the messy world of practice and how, our services run?
I think a lot of the time we look at how complex the environment is that we're interacting in. And I think from my experience, particularly the negative side of healthcare, where we're looking at areas like incident investigation, looking at things where don't turn out the way we expect them to, and where actual harm occurs to either patients or staff. And I think for years and years, we've investigated those incidents. But one of the points I make when I'm doing workshops is that it seems strange that I'm still investigating the same incidents, after 20 years in patient safety and risk management. So there must be some element of it that we're not quite nailing down in regards to causation. And I think over the last 5 or 10 years, the emergence of human factors, particularly in healthcare, learning a lot from other safety critical organizations and industries such as aviation, has really moved us forward into understanding why it may be the case that we are committing errors repeatedly, that we're not learning from issues that arise where we would expect intuitively that we would learn from. And I look at simple things such as communication. And we've looked at practical approaches there, as introducing ISPAR, which identifying the situation and making recommendations, making your own assessment in communicating with other clinicians. And that's a really helpful way of getting to the crux of the matter, rather than maybe the around the houses approach that some of us are very good at. So I think it's really important to look at areas like the effective communication of critical information. That has a direct impact on patient care, as do systems like early warning scores. They're a really good decision support mechanism, simple in their way, but really good at bringing, focusing our attention on the areas where we really need to focus it. And I think in a lot of those areas, we're really trying to offset avoidable deteriorations in patients' conditions. Other areas that we would make the comparison, I think we mentioned cognition and cognitive overload. I think when we look at the analogy between, say, like keypad usage, when we're designing equipment, I would say that using an ATM machine or using a mobile phone is quite easy to key in the wrong number, and we've all done it. But that same mistake brought over into the frontline clinical setting can have catastrophic outcomes for patients, particularly if we're using volumetric pumps with very, I'm thinking of drugs here like inotropes and insulin and such like. You can imagine that the same error that we make with our own everyday device can really have rapid and very meaningful consequences if the same thing happens in healthcare. We've mentioned earlier on about the competency framework, John, and I think a lot of the stuff we're doing now is not only raising awareness of human factors, but really saying, how can human factors impact on a lot of things like, say, decision making? And I think we look at, I investigated incidents. We have the obvious benefit of looking at them in retrospect. So we know what the outcomes are. And that brings its own bias and its own set of kind of rules that maybe stop us getting to the actual crux or the root cause of the matter. And I think when we're doing our education and training workshops, we talk about bias and we use scenarios such as, like, maternity is one of the areas where, it's very media attraction at the moment. We seem to have a lot of issues in that area. But when we look at when things go wrong in maternity, this is relatively healthy people that we're delivering our services to, but yet mistakes or oversights in that area can have catastrophic outcomes. And we look at the role of a bias such as confirmatory bias, where, when we look back, we see clinicians maybe have pursued a path where they've only really attended to the information that fits the decision that they've already made. And that bias then can lead us off down the wrong track and miss out on critical information. Situation awareness is one of the things that would really fit into that as well. When we look at frontline clinicians, one of the earlier speakers mentioned the environment in which we work. It's noisy. There's a lot of distractions. There are flashing lights. Very difficult to even perform a very simple task or to make a decision in that environment. And I think what we really need with our frontline clinicians in particular is to raise their awareness of situations that may evolve and develop quickly in a way that they didn't anticipate. And the SAFE training program, which is John Fitzsimons is directly involved in as well, that really is getting cohorts of clinicians to consider how they behave in particular situations and how they can improve their decision making, their communications, being aware of their own levels of fatigue, those type of things that can impact negatively on a situation. And I think the next exciting things we will do is embracing the whole area of artificial intelligence for everything from diagnostics and interpretation of images right through to the enhanced decision support information that's available now really on people's handheld devices. And that really, in an out-of-hours setting where maybe senior decision-making support isn't available to you, it's really, really good to have that availability of information in a usable format at the real flick of a switch. And that's a really important thing. Finally, I would say we've been doing quite a lot of work in Galway in particular, and I know Liam's been involved with Paul and the team at University Hospital Galway. We're trying to bring in the whole area of simulation. I spoke at the very outset about why are we not learning from incidents. I think our solutions in the past may have been to rewrite policies, impose protocols, checklists. All of those have their place. But I really believe that the way to change actions and behaviors and improve team dynamics is to really embrace an enhanced role for clinical simulation. And we've been using that across all of our hospitals here in the West, Northwest, to develop scenarios, real life scenarios, and to get people to interact using actors and using video and feedback to try and improve people's interactions. And that clinical simulation is a safe, psychologically safe space to do that. So those, John, are just some of the things that we've been involved in. We're always, days like today are really useful for giving people new ideas and to get out there and maybe, get this going on the ground. We do a lot of small and larger workshops over here in the West, and they're really well attended. So there is an interest out there in this particular field. So over to you, John.
That's fantastic, John. Thank you very much. And you know, it's interesting. You say, and I know how you mean it. Like, but you know, it's simple things like communication. But of course, it's realizing that many of these things are not so simple when you go looking at them. And I think human factors is one of those things that gives us the language and the tools, isn't it, to really understand the work that we do and maybe appreciate, you know, some of the trickiness. And I think, like you said, if we're investigating, having those words or frameworks for you know, figuring out what's gone wrong can be really helpful.
I think so, and I also think we've got a changing workforce. We've got our patient demographic is getting older, and those sensory deficits that come with age, as we're unfortunately some of us only too well aware. I think that in itself, communication is far from simple, of course, but we think we do it very well. Whereas there's elements of it that we need to practice and to fine tune, and I think that's the point I would make about communication.
Great. We're going to come back to you, John, in a little while. Thank you. I'm going to go back to Liam next. I think Liam is back with us. Unfortunately, his computer crashed there, as these things are known to happen, of course. And Liam, we're going to pick up where you were, kind of. And I think you know, we've heard from Francesco and from John there. And we're going to hear from them again. But I think they're starting to kind of show some of the applications of some of the ideas that you had been talking about, and I think that you're going to kind of walk us through.
Yep. Yeah, sorry there, blue screen of death randomly on the laptop. So yeah, I mean, John, some of the first work that you and I did together really was on the redesign of the pediatric early warning score observation chart within Ireland, and really looking at that from a human factors perspective and how could we try to optimize it just to improve it for everyday use for people on the front line. And you know, we looked at positioning of fonts and reorienting fonts and looking at the color contrast and, you know, the when it's going to be used at night on night shifts when light was going to be a little bit lower than usual, and, you know, trying to provide examples of how to actually enter the data into the observation chart so that we were getting consistency of performance across individuals. And I think that, I mean, I think that went well enough. It went well enough anyway that I was asked to get involved with the adults early warning system when they were redesigning that chart as well. So being able to apply some of the lessons and some of the lessons that in hindsight we weren't maybe able to, or we made with the Pews chart, to be able to bring it into the news chart. So that's just a very practical thing that probably people didn't realize how much effort had actually gone into that. And that was standing on the shoulders of giants of people who had actually done the initial design of those charts, you know, really from Australia and Queensland, you know, back in the late 2000s. So that's just an element of work. My own work, you know, on a day-to-day basis is really frontline care, standardization of ward-based practices, you know, change of shift huddles for nurses, the night shift handing over to the day shift, so that the day shift nurses are starting on the front foot, and then the day shift handing back to the night nurses, and structure and interdisciplinary bedside rounds for the whole team to have a really brief, focused conversation about each patient each day that is value add for everyone. And we all know there are known complications for hospitalized patients. You know, their blood glucose management, you know, their VTE, their catheter, indwelling catheter, you know, infection control risks around CLABSIs and CAUTIs and all, you know, fall risk, mobility, functional decline, you know, their activities of daily living. How are they faring with these? How is this going to impact discharge? And we know all these things. So, like, let's just put them on a list and make sure that we're discussing them every day for patients, so that we are being proactive. We are not finding out that, oh my goodness, that catheter has been in for 5 days and actually they don't need it anymore because they're able to mobilize and go to the bathroom themselves. You know, let's get ahead of these things. But then once you do standardize this work, you can actually start to align it with organizational goals, you know, and how are we optimizing our throughput? How are we reducing our readmissions? How are we coordinating our discharge process so that patients are getting home safely, either home, or to, you know, a post-acute care facility? And all of this work really is within the realms of a human factors practitioner within modern healthcare.
Great, thanks, Liam, and you know, I'm that phrase I think that Sidney Dekker I've heard use is you know, that safety is the capacity to do work well. You know, and as we kind of start to think of safety like that, we're maybe less interested in one sense in safety and more interested in work, you know, and if we do the work well, you know, that safety is something that the work is trying to do, then if we have the
outcomes will
capacity
follow.
to do it. Yeah,
Absolutely. But I think for most frontline staff, the opportunity to take a step back and consider, are we doing our work well, or how could we do our work better, is not a luxury that very many people have. And I think that's maybe the role for the like an embedded human factors practitioner to fill that sort of void within the healthcare system currently.
Yeah, well, even what you were talking about there with the, you know, all of those human factors in designing the paper record for the Pew chart. Of course, we didn't know many of those things mattered. You know, maybe we vaguely knew about color blindness, whatever. But you know, there's all this science and expertise and research to show that the way you organize these charts, you know, has an important bearing on how well they're going to function.
Yep.
And like you said, knowing where to find the expertise is really important.
Part of the problem, exactly. I mean, there's whole centers dedicated to the design of alarms. You know, I mean, that is just a whole other area that, you know, we haven't touched on.
I'm going to bring in Maureen there from the patient safety group, and Maureen, from the patient's perspective, you know, why is this important? What are the obstacles to a good care experience do you think, you know, maybe human factors can help us with?
Sure. So I'm based in Galway as well. So hello to everyone else from there. And I have two hats on, I suppose, really, because I do work within the HSE as well, and particularly around risk assessment and ergonomics. So obviously I'm kind of embedded in this, but my personal experience would have been through my husband having a significant life-changing accident 10 years ago. And our kind of, I suppose, our experiences as we've gone through, and I say our, even though it's his care, obviously the outcomes, excuse me, have an impact on the family. Sorry, frog in the throat. So some of the obstacles we found, I suppose, have been things that are pretty basic. And we're looking at the people aspect of it, particularly time constraints and the structures of clinics and things like that. So when we're looking at how we set up assessment of the kind of delivery of service, we need to look at how does it work in terms of time. Often they're overbooked. And the health professionals are watching the clock because they know they have a team of people to get through, or a list of people to get through for the day. So time constraints can be a very big thing. And that leads to them suffering from stress and fatigue, which is a human factor which has an impact on service. Inexperience can be another aspect as well. So I'm part of a teaching hospital, and obviously we want people to learn. But sometimes that impact can be significant. If you have a junior doctor coming in who's never seen you before, and you have difficulty talking. So in my husband's case at the moment, he has very limited speech, and I have to be with him. To be asking him the same things over and over again is a bad experience for him, and he has to look to me to speak for him. So it can be difficult in that way as well. And that kind of leads into the communication. Having direct communication, whether it's with the patient, reading their body language is important, and having that history, knowing their file, knowing what's changed for them. And there's also kind of the problem where one speciality, once they've made a diagnosis, they have to realize that leads on to another speciality maybe. So I'll give you an example where my husband was diagnosed with lymphedema from the pelvic fractures. And unfortunately, he got a diagnosis, but it didn't hand over to anybody else. But that has a huge impact on his rehabilitation with physio and things like that. So that kind of communication between departments or between specialities. And finally, the communication between systems. And we found, so he had his accident in Galway, had surgery to stabilize him and transfer to Dublin. And systems didn't talk to each other. So from a patient's perspective, the frustration of me giving them dates of surgeries that they couldn't actually read on the systems was, it gave a definite worry that he was getting full care. It was only based on my memory. And systems whereby if one system, electronics, so we're looking at the age of technology, as you've all said, with AI coming, and it's brilliant to see the changes, it really is. But we have systems whereby if they're not communicated with. So if they're not kept up to date regularly, they can't self-regulate or self-correct if they're not programmed to do so. So again, for my husband's case, he needed interventional radiology and he was on the wait list. And the speciality, the requester, the system didn't keep pushing and pushing. So after 2 faults, you're out. So it didn't happen once, it happened twice.
Yeah.
So I think Don alluded to it in the learning from incidents.
Yes.
And near misses are a huge opportunity. My husband has a lovely phrase. I wrote it down here so I'd remember it. And he said, everything is solution opportunity, if only they'd see it.
Yes, and that I mean that's a great way to think of we have in human factors, I suppose, a way to helping us consider those solutions and a language, that aligns very nicely with the language of patient safety, and the science of patient safety, and so it's very valuable. I mean, do you see, in your experience now, some of those applications happening? Do you see some human factors ideas coming into play and things improving and getting better?
Absolutely. So Gabriel has been within the service for this accident for the past 10 years. And in that time, things had definitely changed. Now, it's a slow wheel to turn. We all know this. But as long as it keeps turning, we're heading to the right direction. He now has, unfortunately, a life-limiting respiratory condition. But I think it's through assisted decision-making, and that's now it's an act. So that kind of legislation has fed onto things. Open disclosure, fantastic piece of policy around that. And that all helps with people feeling free, changing the culture that they can explain, they can talk, and they can admit when things have gone wrong. And there's no problem saying to a patient or a service user or their families, listen, this didn't go as planned, but we want to know, and we want to know what can be done about it, rather than someone just covering it up. We have a consultant now who just pulls up a chair, and what I love is no longer is Gabriel referred to as the complex acetabular fracture in room 11. He is now Gabriel, and they will ask him, what do you want? How do you feel? Instead of telling him what he should feel at this stage. So yes, it's definitely changing, which is for the better.
Thank you, Maureen, and yeah, I'm glad to hear that. And I think, even concepts like, just culture, I think that's something that has helped us kind of, I suppose, to frame a lot of these changes, like open disclosure. And I think that has, I think, a background from human factors itself. Yeah. Maureen, stay with us, and we'll get you back in the panel. I'm going to go back to Francesco. Francesco, I'd like to hear a little bit more what you were talking about, the use of simulation in your work and your experience with that, and in particular as a way of helping you to apply human factors ideas.
Yes. First of all, I would like to underline a few concepts. I mean, communication mishaps and teamwork mishaps are at least the root cause of at least 75% of adverse events. So if we understand the meaning of a good communication, good handover, as we already listened, and a good teamwork, we could implement patient safety in a better way. My experience, being a frontline emergency surgeon, I used to observe what happens in an operating room. I had the opportunity or the luck of looking at a video clip done by Martin Bromley. Martin Bromley was an English pilot, and it was just a routine operation. That video clip really astonished me very much. So I said, let's see what happens in my experience. So I spoke with the chief of my surgical department, and I said, can we video register what happens in an operating room? Of course, with the consent of all the healthcare workers. And it was a very big project. We did it in at least 2 big major teaching hospitals of Florence, of my community. And what we did, with the help of psychologists, human factors experts, we reviewed the film and we understood what were the major mishaps. And what we did is use simulation criteria to improve our non-technical skills. And it really worked, because we had a slight decrease For example, in wrong side surgery, we had a slight decrease in medication errors. We had a very important decrease in communication errors. And so I decided to apply what the pilots do in aviation and transfer it into the operating room, because the operating room is a big cockpit. And being a big cockpit, we have relations between ourselves. But actually, are these relations governed very carefully? What about one of the biggest mishaps that could occur, which is a situation awareness? So I believe this experience, and then I brought it on a national level, and we approved it as the Italian Society of Surgeons. We approved it as a best practice for education and training of young specialists in the fields of surgery. And now it's extending to the other fields. But, and the last experience that I would like to talk to you about is that we have to, if we want really to teach human factors and have them be significant and have an effective effect on healthcare and patient safety, we have to teach these before being doctors and nurses. I mean, we have to teach them in the medical school. And so I talked about a year and a half ago with the dean of the Faculty of Medicine here in the University of Florence Medical School, and we have the opportunity to teach these human factors issues with simulation scenarios to the students of the 5th year of medical school and the nurses in their 3rd year of nursing school. And let me say that it was a very, very astonishing, exciting experience with a lot of let's say admire to these things. So now we're going to talk about institutionalizing it in the 6th year of medical school and in at least 3 major specialties: anesthesiology, general surgery, and emergency medicine. So this is my experience. I have a positive effect. And let me say to you, we also improved our relationships among the surgical teams in the operating room.
Thank you, Francesco. That's fantastic. And I think we'll come back to maybe talk about some of those things in our panel discussion as well. I've just put a link up there. There's a piece, commentary myself and Peter Lachman, who I think people will know on the podcast, who's worked for many years with the Royal College of Physicians of Ireland in patient safety and including the SAFE program, but arguing for exactly that you know, it was a commentary on a piece about building psychological safety competencies into the undergraduate program for medical trainees, but I think it goes for all healthcare trainees, and how we, you know, that's a critical thing that needs to be done alongside teaching people about patient safety before they qualify. Speaking of competencies, then I'm going to ask Veronica maybe to share with us some of the resources. And Veronica, the HSE has been working for many years now to promote human factors, ergonomics, and in particular its application into patient safety. And there are many resources, including the competency navigator that we mentioned earlier.
Absolutely, John, and apologies, there are a few gremlins in the system, so I can't get my camera working, but hopefully you can hear me okay.
Yeah, I can hear you there.
Great, thank you. So in terms of learning resources, we have done a lot of work over the last couple of years, and what I'd encourage people to do, you know, as a starting point, is access our recently launched Quality and Patient Safety Competency Navigator. And it was really interesting to hear Francesco talk there about the importance of communications and teaming, because in that resource, we have a whole topic area dedicated to communication systems and teaming. So you can access the navigator either on our website, or there's a QR code there, and hopefully we can share these slides later with people. When you access the navigator, you'll have an opportunity to select your particular role within health services and select a topic to explore. So our role categories range from people who are absolutely new, maybe to human factors, or those people who are fairly experienced but want to develop some mastery around the topic. So when you select the topic area, communications, teaming and systems, it'll bring you first of all to a couple of explainer videos that just talk about, what we mean by communications, what we mean by teaming and systems. And these videos feature people who already work in healthcare in this whole area. After looking at the explainer videos, you can then go on and explore the competencies that are related to this topic and your role. You can identify the ones that you feel you need to learn more about. And then when you continue on through the navigator, you'll be given some suggested learning resources. So what we've done here is we've broken the learning resources down into 4 kind of groupings. So you'll see in the navigator, we've got some suggested programs that you can attend. There's some further learning resources. So these might be, websites that we'd encourage you to visit. There are some key policies, procedures, guidelines that you can reference. And what we've done in this resource is we've tried where possible to provide you with the hyperlinks so you can go directly to the resource. But we're very conscious and very aware that, people are finding it may be challenging to take on formal training. So we've given some suggested ways that you can learn about this topic while you work. So again, I'd encourage people to go in, just have a look at what's there. You mentioned it at the outset, John, but our annual prospectus of learning, education and learning programs has just been recently launched as well. And we launch and publish this usually around January every year. But if you have a look at the prospectus, and there's lots of quality and patient safety programs there, one of them is an introduction to human factors. And this is a very short 20-minute module that sits on HSE land, but it just gives the history of human factors, the evolution of human factors in healthcare, and again, some videos of people who are, demonstrating some good human practice, communication and teaming in practice. So again, the prospectus can be found on the National Quality and Patient Safety website. And again, we've just given you the QR code there if you want to access it directly. Lastly there, John, if anybody is interested in maybe doing some formal education around human factors, this is a list that was compiled in 2023 by some NQPSD colleagues, Dr. Mary Brown, Margaret Codd, who I'm sure some of you are familiar with, and our colleagues in NUI Galway. But there are some good postgrad training programs available. And again, we've hyperlinked them here for you for ease of access. Again, these are just some useful resources, and you'll see them referenced within the Competency Navigator. And again, the Introduction to Human Factors in Healthcare, which was developed, by our colleagues within National Quality and Patient Safety and academic partners in NUI Galway, is a really good, foundational guide that I'd suggest you have a look at. So again, these will all be available if you want to look back on this QPS talk time, or available as a reference from the slides if you would like that.
Great, thanks, Veronica. And we'll put some links up in the chat, and we'll have some links on the website afterwards to some of those resources, including the ones on HSE land, and the document from Paul O'Connor and Angela O'Dea, which is really a great introduction to human factors in healthcare. So lots of resources out there. People are wanting to learn more. I'm going to bring everybody back together. That the clock is against us, but I think we might have time for one or two questions. And Liam and John, just before we see if Juanita's got some questions for us, you have some experience of simulation as well, isn't that right? And obviously we have the ICAPS Centre in Galway, who have really kind of pioneered a lot of this.
Yeah, we'd take very specific scenarios in Galway, and they're very professionally done. We have members of the public, people who have actually experienced the type of incident, particularly areas like Francesco mentioned, surgery, maternity. An ever-growing number of scenarios that we've got. They're well acted out. They're very realistic. I've sat through numerous of them, and the feedback sessions then are very honest. It resonates very well with frontline clinicians. because they're learning from participating, but they're also learning from the feedback of colleagues.
Fantastic. And again, having a language, that comes from simulation, the science of simulation or from human factors is so valuable. And Liam, I know you've been involved with simulation as well, but what are the other ways that people can easily start to get involved here? I think everybody's afraid with human factors that we don't know enough. We'll do it wrong. We'll make a terrible mistake. How would you tell someone to start using it and applying the ideas?
I suppose the first, if you're dealing with in hospital patients, I think the easiest way to get into human factors is to ask your patients, what is your goal for the day, or the what matters for you movement. And I think that has a real humanizing effect on the patients themselves and for the staff. And I think it shifts the mindset of the care delivery into meeting the patient where they're at. And it might be something as simple as, I would like to get some more information about where I can go for rehab. Or it might be, I'm really bored and I would like to have some puzzles to do. Or I really have you've told me I've got a new diagnosis and I'm really thrown by it, and I could really use some more information about how this is going to impact me going forward. But I think that simple question can be really sort of enlightening for people. And I think if you wanted to take a step up from that, if you have the time, consider the work that you do, your work as done versus the work that, is designed. And, if you are hit by a bus, and you are the linchpin in the service delivery, how will the service continue? How will somebody else be able to slot into your role? I know you want to make yourself invaluable, but make yourself invaluable in such a way that the service can continue to be delivered. And if that's something as simple as just some box and arrow diagrams about, I do this and then I do that and then it goes to this place, that's a great start. You can start off with that and you can look to level up. And I think the last thing maybe, the QPS has some resources around the Yorkshire Contributing Factors Framework for incident analysis, which is a really nice, just 2-page tool to help guide you, prompt you across several human factors domains with some really key sort of sub points to consider. So whether you're analyzing an incident or you're just sort of trying to get your head thinking like a human factors practitioner and the broader scope of your work, have a look at it. Have a look at what it is sort of prompting you to think about. Local working conditions, communication, organizational factors, all of these things. Which of those are within your own remit to change or improve? Which of those do you maybe need to pull some extra people into? And which are the ones that are really problematic that you need to bring senior leadership into? I'm not saying you're the person who's going to be able to bring senior leadership into it, but maybe you can start the conversation to get them working towards that sort of broader improvement.
Thank you. That's great. And I think that, and I came back to your definition, those two key things that you're trying to get, human well-being and human flourishing even, and overall system performance. And how do we get those two things, and I think if we take this approach, we can start to do that. Now, I see one of the questions in the chat is from Marie Ward, is where can we continue these great discussions on human factors in healthcare? Now, I think that does bring us to, we are very fortunate to have the HEPS meeting here in Dublin in June. And Francesco, you're going to be at that meeting. What will you be talking about at the HEPS meeting?
The experience among surgeons, because sometimes I ask my colleagues, let's see it from a patient's perspective, what patient safety and human factors are. I mean, sometimes we can be on the other side of the border. We can be patients. So what would we want from our healthcare system and from our colleagues?
Great, fantastic. And Liam, you're at HEPS as well. Have you something you want to talk about?
Yeah, I'm at HEPS with Angela O'Dea from the ICAP Centre here in Galway, and we will be providing a 1-hour breakfast session as an introduction to human factors, with some introductory theory and some practical cases, and very open to Q&A and how you can get involved and how you can learn more.
And Maureen, you're looking forward to HEPS too, I hope.
Absolutely. And I think Francesco and I are on a workshop together, and it's going to be a great way for networking It's a great opportunity as well for me to bring forward the patient's aspect on it and test it all by the patient. They'll give you an answer as whether it's working at the front.
Fantastic, and I know, John, hopefully the HSE will be well represented there too, you know, so this is a really unique opportunity. This is a global meeting that only comes around every 4 years, so it's a real honour for it to come to Trinity College in Dublin from the 18th to the 20th of June, and we'd certainly encourage people to come. Juanita, have we any questions there? I'm conscious we're right up against the clock.
Yeah, absolutely. It's always one of those topics, I think, where you could continue to talk into the afternoon. I just have one question, and it comes back down to the perception sometimes that human factors is predominantly communications and patient safety, but we've heard today that it's much more. And maybe if I just come back to Francesco, you've obviously been involved for a considerable period of time in this space. What has helped change the mindset so that people think of it in broader terms?
Well, the mindset, we have a lot of work to do on that. We have a lot of work ahead of us. And as I said, if we don't start beginning in the school, in medical school, and nursing school, we're never going to have these issues really acquainted with the future doctors. I mean, healthcare worldwide is now suffering a very critical crisis. I mean, also motivation, getting to be a doctor or be a nurse is, you talked about well-being. In my country, we have a lot of aggressiveness. We have a lot of assaults to healthcare workers. So we have to work on these, and we have to involve patients, involve citizens, involve politicians and the political institutions. We have to. It's a must. And I hope that the next Congress that we're going to have on HEPS in Ireland will be the main root, the main driver of all these issues worldwide.
Fantastic. And I just wanted to point out as well that Marie Ward had shared a really useful tool around AI and human factors. It's in the chat, and to signpost as well, the Equips Network are doing some research in this area. So do take a look at the chat. You can select all and copy and paste it if you want to look back at it later on. But in the interest of time, with our 1 minute left, John, I'll go back to you. And thanks so much to our panel today.
Thank you. Yes, and let me reiterate that. Thank you, Maureen. Thank you, John. Thank you, Francesco. Thank you, Liam. Thank you, Veronica. You've been fantastic. The lovely feedback in the chat there. I think people have enjoyed the session. And I think we may have whet some appetites to continue the conversation in June at the HEPS meeting. So again, I just want to thank Juanita and Chris, who do all the work in the background preparing these sessions, and again, our panelists. We have a few more QPS talk times there, you can see, and integrating patient safety from education to practice, designing work survey. So these are all, if you follow the QR code there, you'll pick those up, and you can watch back our previous episodes on YouTube, and as you heard earlier now, on Spotify also. And please do share them with your colleagues if you find something interesting. And that's it from me. I'm going to thank our panelists again. Thank you very much. And we'll see you at the next QPS talk time. Thank you. Goodbye.